it can be kind of risky to share my authentic story in the health system because I run the risk of giving an overly positive impression of myself. I also run the risk of potentially burning bridges and maybe even putting my job security at risk. But I think that there's enough people within the health system like me that have a story that needs to be told that I think it's worth the risk. I'm Dr. Chad Swanson. I'm an emergency physician, and I'm on a journey to understand and transform our health system. As I share my experience, I want to make it clear that I'm not blaming anyone particularly. We all inherited a system that's incredibly flawed. We all live in a culture that's imperfect. My friends and colleagues in healthcare, in public health, in health education and research are some of the most brilliant and caring people that I know. We're all just doing the best we can as flawed human beings. Some of you that know me, if anybody that knows me happens to watch this video, will know that I haven't implemented many of the things that I either criticize or claim should be ways forward in this video. So my intention is not to set myself up as some type of model or example for people to follow. I'm more interested in just sharing my authentic experience and hoping to contribute to or catalyze a more earnest discussion with action around transformation of our health system, because so much suffering and lives depend on it. I'm going to be referring to these figures here, so I'm just going to briefly introduce them. This figure represents the current system that we inherited from over 100 years ago. So each of these circles represents a subsystem with kind of clear boundaries, and each subsystem has goals that are unique to the subsystem and that may or may not contribute to overall health and well-being for all at the lowest possible cost to the system. So what we really want as a society is often lost because these subsystems are focusing on different metrics. And I hope that becomes more and more clear as we talk. This figure, I think, represents a more ideal system. So it looks more messy. There's arrows kind of going all over, but there's one big arrow, and that's that it's pointing towards what we as society really want: health and well-being for all at the lowest possible cost to the system. And there's kind of a banner here that keeps everything together. And I would argue that that banner represents a shared vision and aligned incentives. So I entered medical school, I think many, with a sense that, number one, I wanted to help people. Number two, I wanted a career that was interesting. And number three, I wanted to make good money, enough money so that I could live a comfortable life and travel the world and have fun vacations. So I think many pre-medical students share those motivations. There was a sense that I wanted to contribute to health and well-being of our society. There was a sense that our health system was very flawed. There was a sense that things could be better, but that wasn't clearly understood for me as I entered medical school. The road to medical school in the university was intense and competitive. While I majored in philosophy, and you can major in anything you want currently to go to medical school, there are prerequisite classes in physics and chemistry and organic chemistry and biology and other classes. And so those classes were very competitive, and I spent many hours stressing and being anxious and working hard and memorizing many equations and details that I would never even think about or use again. So I'm going to pause here briefly, because our pre-medical system, one of these circles might represent pre-medicine, and the focus is on memorization and understanding basic science minutia that won't necessarily make someone a better doctor. Those minutiae might have made more sense 100, 140 years ago when the world was completely different, but that is an incredibly large factor in getting into medical school. Whereas I would argue many of those facts aren't necessarily needed, and there's other topics that a pre-medical student could and should learn that there isn't room for because we're hyper-focused on these other topics. I strongly recommend that, effective immediately, all pre-medical students major in health systems transformation. And I'm not aware of any undergraduate schools that has a major in health systems transformation. There may be one. I know ASU has a few that might be similar, but I envision a major with courses ranging from epidemiology to statistics to the social determinants of health to health economics, health equity, the history of health and medicine. So all with a foundation of complex adaptive systems thinking, the theory and tools around complex systems, so that all pre-medical students can enter medical school with a clear understanding of the driving forces of health and medicine and the need for change. Another class that I would recommend is social change. I also strongly recommend that all other health professionals, so whether it be nursing or public health or health administration, at least minor in health systems transformation. I think that the need is urgent, and so we need to take some drastic steps. Okay, so I entered medical school, and it was, I think as most know, an intense time. It was 4 years of lots of memorization. And then you could say memorize and regurgitate. So to a large degree, we would memorize many anatomical details or biochemical details. And many of them, maybe even most, we would forget, or some would even become irrelevant as new data comes up later. So similarly, medical school is a controlled, uniform, set period of time, currently 4 years with a few exceptions, I guess, that has remained, I would argue, largely unchanged for over 100 years. So there are subjects and details that simply aren't relevant to the practice of medicine today, or aren't as relevant and important as other topics that I'll get into. There's a doctor, I think Casey Means is her name, that very eloquently made this case, and I'll leave a link to the speech that she gave, I think is before the Senate subcommittee on this topic. So I have two recommendations for medical school. One is that, again, we require a health systems transformation major. And then number two is that the requirements of medical school be more personalized and adaptive. So to give us an extreme example, if there is a nurse practitioner that's been practicing family medicine largely independently for 20 years, and let's say that she is outstanding in every way, every metric, she can perform procedures and her knowledge base is outstanding, she has excellent rapport with her patients, it makes absolutely no sense for her to go through 4 years of medical school, go into debt, lose that income generating time, and then go through 3 years of residency. It would make more sense to have an adaptive time, maybe a year or two, where she could focus on the skills and knowledge that she needs and then become a physician if that's what she desired. So medical school for me was a very intensive and immersive time where I was focused on memorizing minutia without an adequate consideration for the key drivers of health, without an adequate consideration of the system and the culture of medicine and healthcare. And so that's medical school. I chose emergency medicine as a specialty. And for me, the emergency medicine residency program was 3 years long. And again, it was a very intensive program where we were junior doctors who had graduated from medical school but were not yet board certified. And this was a time when we'd work up to 80 hours a week. And everything was focused very intensely on the clinical encounter before us. And in emergency medicine, that's extremely important, that we take care of a patient in anaphylactic shock, or learn when to place a chest tube in a trauma patient, or know who to call and when to call the cardiologist if there's a heart attack, or to decide who we could or shouldn't send home with appendicitis. However, and this might come as a surprise to many, I would estimate, and I'm sure there's data on this, but I would estimate that at least 70% of patients that we see in the emergency department are acute exacerbations of chronic problems. So it's patients that have migraine headaches, that have a flare of their migraine headaches, or they're patients with chronic abdominal pain who don't have a surgical emergency but come into the emergency department, or people with chronic anxiety who then have panic attacks, or people who have alcohol use disorder and come in withdrawals. So the majority of patients that we take care of in the emergency department aren't having an isolated episode of emergency. They are on a continuum. They're on a journey. They're on a personal journey that they've been going through for weeks or months or years, and that journey will continue after that visit to the emergency department. So while my residency was extremely valuable and appropriate for isolated episodic emergency care, it did not adequately consider the journey of health that we all go through. And that has significant implications for our health system that I'll get to in a minute. Also in our residency, there was very little consideration of the cost of care. So we live in a culture and we have inherited a health system where at the end of life and in emergency situations, we will do anything at any cost for anybody, even if the evidence for what we're doing is either poor or non-existent. So we'll often do repeated CAT scans, or we'll fly people in helicopters, or we'll admit them to the intensive care unit. And I'm not suggesting at all that those things shouldn't be done if they're needed. I am suggesting that we as a society, we as a health system, can do much better at deciding when our resources are best needed and where they can be best placed. Okay, for me, residency was, again, very intensive, very consuming. At the time of residency training, I had a young family, and it was very taxing on me and the relationships that I had in my family. But we knew that going into it. We knew that it was going to require a significant sacrifice. I remember at one point I decided that I absolutely could not get less than 5 hours of sleep. So I was getting enough, I was going enough nights without 5 hours of sleep that I decided that I absolutely had to do that. And yet sleep 7 to 9 hours a night is a significant determinant of health, of physical and mental well-being. So I would argue that residency training as we now know it, the type of residency training that had its roots in Johns Hopkins in the early 1900s, in a completely different time when there wasn't the internet, there wasn't AI, there wasn't the knowledge base that we have today, there wasn't the broad professionalism that we have, there weren't physician associates and advanced practice providers like nurse practitioners and physician's assistants. It's a totally different world. And the residency training program as we know it today, I think should gradually be dissolved or dismissed or set aside. Like I said before, I think a better model is to go from one profession to the next. So someone might start out as a nurse and then decide to go into nurse practitioners as in a neurology clinic, and then take a year or two or however long it would take to then become a specialized neurologist. That would take years for us to develop that system, but that would be my recommendation. So after residency, I started my practice as a full-time emergency physician in the clinic. I also at the time developed some interest in global health. So I the suffering that was going on in Africa and other places around the world just felt unacceptable to me. And so I spent some time training in tropical medicine in Peru, and spent some time seeing patients and organizing public health programs in Mozambique. And then I ended up getting a master's in public health with an emphasis in global health from Johns Hopkins University. So my experience in global health was similar in that as global health practitioners from the United States and other countries, we would often come with a specific mission in mind. So that mission might be, we might receive a grant to treat people with HIV/AIDS. And then we would focus on that without adequate consideration of local education, local professions, local clinics. And they were kind of focusing on their own issues. And that had serious potential negative effects as far as duplicating services or undermining the local capacity. So again, in global health, I envision an ideal situation where if we choose to engage in global health, we recognize that there's already a social system in place. There's physicians and nurses and churches and community groups and neighborhoods that are already interacting with each other in certain ways, or a culture, and we need to learn to incorporate what we're doing into that culture and learn from them as they learn for us, etc. So that was a little bit of my experience with global health. I spent a few years as an adjunct faculty at a university. I was teaching classes in global health and also in systems thinking or complex adaptive systems. As an adjunct faculty, so we can imagine that one of these circles represents a department of health in a university, whether it be public health or health sciences. And the boundaries are set by my understanding. And again, let me just give a disclaimer. My experience with universities is very limited. So I've never been a full-time faculty member at a university. And so these impressions are just my bias and my limited experience. But the required classes, the focus of the department, who to hire and who not to hire, were all determined by full-time tenured faculty. And so, again, we've inherited a system that's over 100 years old in our universities, where faculty will rise in rank over time, and there's a tremendous pressure to publish and to receive grants. And so if there were a community member or a faculty member from outside the department who had innovative, progressive ideas, then those ideas would potentially be left out because of the boundary that's placed on by the tenured faculty. My experience was that as an adjunct faculty member, I largely had to teach classes at times that were less convenient for me. And again, I understand that I'm not being critical at all, but I'm just describing the reality that adjunct faculty who might have valuable clinical or community on the ground experience might be left out on key decision making and class teaching opportunities because of the focus that's placed on what is determined by the full-time faculty members. So eventually I decided that it was best for me and my family to not continue as an adjunct faculty member. I envision a university system, especially the state universities, to be more of some type of steward of the health of the community. So you might imagine a department that commits themselves to improving the health of the community. So their research, their teaching, who they hire, are based on the needs of the community at that point in time. So I'm thinking of maybe if we think of mental health issues in a community, or if we think of opioid issues in a community, instead of reacting to those issues 7, 8, 12 years after they began, we could be responsive to them using data from public health and then local research from universities, and communicating and sharing with shared data with clinicians in emergency departments and family practice clinics and others to address issues more nimbly and adaptively and urgently as they come up. I was just very superficially in communication years ago, 5 or 10 years ago, with Arizona State University, and they seem to have a model where there was this sense of responsibility towards outcomes in the community, and they would adapt their institutions and departments and faculty to meet the needs of society, and that is, I think, an ideal situation as we think of the needs for our society today. I was at one time offered a full-time tenured faculty position at a university, and I was very excited about the opportunity. And I started contacting others within the university, and eventually that position, that opportunity was removed. So I was told that I no longer had the opportunity to be hired. And as I dug deeper and tried to find out why, it was revealed to me that there just wasn't time. There just wasn't time to have discussions of transformational change, because that's what I was most interested in discussing. Now I don't want pity. I'm in a great place. I'm a full-time emergency physician. So fortunately, the financial aspects of things aren't as big of a deal for me as they would be for many. I've got a great family. I've got good social support. So from my perspective, these issues on a personal level aren't a big deal, but they did give me a window into seeing how universities operate. And it seems to me, and I'd love feedback or criticism, but it seems to me that there isn't much of a focus on transformational change to meet the needs of society. So I've worked for now, I guess, going on 20 years as a full-time community emergency physician. And I'm just going to say it again, the physicians and nurses and the rest of the team that I work with are outstanding. These are brilliant and caring people. And I work within a health system that is considered one of the best in the nation. And so I don't want to be critical of any person or organization. I'm trying to share what I see as a common experience throughout our entire country. And that is, as emergency physicians, we are focused on, I would say there's two main issues that drive us. Number one is outstanding episodic emergency care. So we ensure that we give the best care for that individual that's in front of us at that given point in time. As I discussed, we were trained to do in our residency, and that's what we talk about, and we review cases and we learn, and there are a variety of ways that we are required to engage in ongoing learning over time, and we're quite good at that. Having said that, there is not a recognition and incentives and a vision for overall health and well-being for our society. So again, as we think about the practice of emergency medicine, we are very focused on outstanding episodic emergency care. And the second driver is volume. We get paid by fee for service. So if we see more patients, we get paid more money. And so we want to see more patients as well, without adequate consideration and adaptation to meet the needs of society. So there are regulations and financial pressures and opportunities that result in us seeing patients quickly making sure that their immediate emergency needs are met without an adequate consideration and collaboration and discussion and communication and incentives to enhance the health and well-being of patients, given that they come to our emergency department in a journey. So they come with their mental health issues or metabolic issues that have been going on for months and months to come. So this, of course, is a daunting issue. I don't pretend to have any enlightening answers today, but it is helpful for me to think, okay, if we as emergency physicians were incentivized to improve the health and well-being of our society and not only see this patient in front of us, how might things be different? And I start imagining an entirely different way of going about things. There might be a dermatologist that would receive pictures of rashes that could be looked at and we could consult very quickly. Certainly primary care would really need to be bolstered significantly. And all these changes would need to come through co-evolution. So education and training would need to co-evolve with the way that we as medical professionals practice, and that would need to co-evolve with policies. So I'm in favor of basic universal health coverage for all. I'm also in favor of abolishing fee-for-service. And so my experience in emergency medicine and in medical practice is that if we or if any healthcare provider keeps focused on outstanding episodic care and and continuing to provide the volume that is required to financially keep the medical group and the hospital going, then they will thrive. But if there is an interest or a drive to improve the overall health of the community, that's very challenging. And for me, that's meant changing my emergency practice to a less busy practice so I could focus on issues like writing and creating videos like this. So again, I realize that my perspective is biased, that my experience is limited. I was inspired by Dr. Gooby. Some of you may be aware of him. He's a neurosurgeon who quit and is now producing YouTube videos about wellness and being in the outdoors. And I'll leave a link to his video. But I think stories are powerful and important. I think those of us that choose to stay in medicine also need to tell our stories. Although it is a little scary. It is a little scary to get my word out and not know how it will be perceived or taken. I am going to leave a hashtag #MyHealthSystemStory. And my hope is that some of you will also share your story. I encourage those of you that are at a CEO level or kind of a high level in healthcare systems or in public health or in businesses or in politics, that you make it clear that optimal health and well-being for all at the lowest cost to the system is important, and that message can be received by everyone in the organization so that they know that it's safe. It's safe to share your story. It's safe to speak up. If you're in a middle administrative position, so maybe a department head at a university or a manager in public health or a physician leader within your specialty, I recommend that you make it clear that you're interested in hiring and incentivizing people that are in your organization to bring up ideas related to positive transformational change. And then finally, I encourage us all to speak up, to connect, to share stories so that we can transform our health system into a system that we can all be proud of, that focuses on health and well-being, not just rescue care and profits. And thank you very much.